Even if you have Netflix, you don't have to open the app. Just click on the link and it will take you to the quiz page for today's quiz. Okay, so if you answer fast, you get slightly better points. All correct answers get +3. Unfortunately, strict quiz master, wrong, incorrect answer loses 1 point. But the good part is only the first 10 names will be known. So all of you can be the 11th in the rank.
Yeah.
Okay, try to look into your phone because the screen here will not be very clear. Tushar, you have the print to read this?
Yeah, I have the print to read this.
Phone. Are you all able to see on your phone clearly? Okay. You're not able to mark? You will be able to mark.
What is already marked? Sub-arachnoid, right? No, this is an old quiz. This is not the quiz. This is a dummy question. Yeah. So your this will come after we. So let us start and see what happens. Let's begin the
Okay.
quiz. Good luck to you. Let's go.
Round 1.
There are 2 rounds, 14 questions per round. Nintedanib and pirfenidone are principally useful in which one of the following? Don't answer loudly, please. Just click on the correct answer. Only 2 options are being given to make it a little easier. There is a timer there. It's 6 seconds more. After which the answer will, the thing will close. Submission will close. Now we are calculating your score. Those who have answered will know whether they are right or wrong. So nintedanib and pirfenidone are principally useful in idiopathic pulmonary fibrosis. We'll discuss this after we have finished the quiz. Next, please. Daily roflumilast or daily azithromycin are considered oral add-on therapies in which one of the following? Severe COPD with frequent exacerbations, severe asthma with frequent exacerbations. 10 seconds left. COPD is the correct answer. Most of you got that right. Next slide, please. Modafinil or armodafinil are more useful in which one of these? OSA with daytime somnolence despite CPAP, OSA who refuse CPAP. More useful in which one of these conditions? These are all pulmonology questions till question number 8. The first answer is the correct answer, 56. You will see that 99% are giving answers, 1% are not giving answers. That is because Maniyar and I have the app too. Next, please. Which one of the following is now a pulmonary indication of gabapentin? Gabapentin can be used in pleuritic pain of post-Cox pleural thickening or symptomatic treatment of non-resolving dry hacking cough. It is symptomatic treatment of non-resolving dry hacking cough. Next, please. Why are inhaled corticosteroids not the first line agents in COPD? Greater risk of systemic absorption through diseased bronchial tree or lesser efficacy than in asthma, and greater risk of pneumonia. The answer is lesser efficacy than in asthma and greater risk of pneumonia due to inhaled corticosteroids in COPD. Next, please. In URTI, if an antibiotic is started, then one realizes that the infection is actually viral, one must complete the course of the antibiotic or one must discontinue abruptly. I'm keeping fingers crossed that this will be 100% one-sided. Well, no. Okay, one must discontinue abruptly. Next, please. 4 puffs per day of Seroflow 250 or Furacort 200 metered dose inhaler can cause adrenal suppression, osteopenia, and cataract. True or false? Long term, of course, 4 puffs a day for a long time. Okay, it is true, though, yeah, it can cause the systemic side effects of steroids. Next, please. In COPD exacerbation, which one of the following must be given? Mandatory. Antibiotic course like Augmentin 625 TDS or steroid course like prednisolone 40 OD for 5 days. Steroid course is mandatory in COPD exacerbation. Antibiotic course is optional depending on fever, etc. Next, please. Vonoprazan is a new molecule in gastroenterology pharmacology. What is vonoprazan approved for? GERD and H. pylori or chronic constipation and IBS? GERD and H. pylori, this is a new drug and we may be using it a little more than usual. Next, please. Now you have started gastroenterology, right? Next, please. Acotiamide or cosiamide is useful in which one of the following? Postprandial fullness due to non-ulcer dyspepsia or GERD? It is useful in postprandial fullness symptomatic therapy. Next, please. Prucalopride, which costs about 23 rupees for 1 milligram, 36 for 2 milligram, is a prokinetic drug. It works chiefly on the esophagus or the colon. It works chiefly on the colon, useful for constipation. Next, please. Sodium alginate, a component of some antacid liquids, is a medicine that forms a raft above the acid that has refluxed or coats the esophagus mucosa. Forms a raft is the correct answer. All of these will be discussed soon. 13th question. Mebeverine in doses of 135 TDS or 200 BD is principally indicated for what? Intestinal colic or chronic diarrhea of IBS? It is intestinal colic, not diarrhea. Next, please.
Last one for round one.
Last one for the first half of the round. Rifaximin 550 TDS for 7 days is the preferred regimen for what? Traveler's diarrhea or SIBO, small intestinal bacterial overgrowth. 550 TDS for 7 days. It is SIBO. Small. This is the first time majority have not given the correct answer. SIBO is the correct, the regimen for traveler's diarrhea we'll discuss is different.
I think we are at the end of round one, so we'll show the scores now.
Yeah, we'll get the scores of the top, we'll get the top 10 here on the leaderboard. Dr. Afnan Kazi, Dr. Rathod, Girish Mehta, Jehan Cooper, Leena Bhagat, Mala Mange, Mukesh Bhambre, Sheila Rathod, Sushil Shah and Trupti Chatwani. Yeah, there are some old names here for me, there are some new names. Who's Dr. Kazi, Afnan Kazi?
Please note these are alphabetically arranged
Oh, is
of
it?
these
Okay.
top 10.
Okay, who's Kazi sahab? Koi hai? Hi, how are you? Afnan, thank you so much. Lovely participation. And who is, I'm just asking for people I don't know. Trupti Chatwani, I probably know, but I'm not sure. Please sit, please sit. Okay, these are the top 10 so far. Top, not in order as he said, they are alphabetically arranged. And should I go with the discussion for the first 14 and then?
Sure.
That may give a gap. So 14 question, page number 25. Turn to page number 25 in your book. So I'll just discuss the first 14 questions a little detail. If you have any questions, please feel free to ask without any guarantee of a good answer. Nintedanib and pirfenidone are principally useful in IPF. There are multiple forms of interstitial lung disease. Unfortunately, what happens is that these two drugs are used when they are not indicated also. So how do you know that a disease is IPF? Idiopathic pulmonary fibrosis. IPF has a very characteristic CT scan pattern. The CT scan pattern is called UIP, usual interstitial pneumonia. If a CT scan of a patient with interstitial lung disease comes as UIP, you know that you can almost certainly presume that this is IPF. And these patients will respond to this. But if the patient has sarcoidosis, for example, and has interstitial lung disease, then these drugs are not indicated. These are anti-fibrotic drugs which don't cure the disease, but they retard the progression of fibrosis. So they will be useful in which disease? Early stage or late stage? Early stage. So the other mistake that happens is these patients continue to get the medicine even after they have developed late stage fibrosis. Any patient who is on 24 hours oxygen of IPF, then probably the medicine has stopped working. UIP, usual interstitial pneumonia, typical CT scan pattern is honeycombing, and typical clinical findings are coarse Velcro-like repetitions and clubbing. So these are the typical findings of, and as you know, IPF usually presents in the age of 50s or 60s, more common in females, and presents with exertional dyspnea and dry cough. This is the IPF typical presentation. Okay. Hypersensitive pneumonitis is a form of interstitial lung disease separate from IPF. So that is the second most common form of interstitial lung disease. First IPF, then hypersensitive pneumonia. Unfortunately, HSP or hypersensitivity pneumonia does not have significant therapy. People give steroids, but we don't know whether they are really effective. Okay, so you have to remove the causative agent, like farmer's lung is a form of hypersensitivity pneumonia. You have to remove the exposure to the antigen. For pigeon, for example, pigeons are sources in urban areas. Daily roflumilast and daily azithromycin are considered oral add-on therapies in severe COPD with frequent exacerbations. If you have a COPD patient who has predominantly chronic bronchitis, you know COPD has two components, chronic bronchitis and emphysema. If you have predominant chronic bronchitis in a patient with COPD, mostly a smoker, and the patient is getting frequent breathlessness, frequent productive cough, then these patients, azithromycin every day for life can be given. Every day, 250 milligram azithromycin for life can be given. Or the other option is a drug called roflumilast, which is different from montelukast, another group. So these two can be used. Azithromycin is the cheaper, so more commonly used. In which patient will be considered severe COPD? Those who are already on triple drugs. Triple drug, they are on LABA, LAMA, and ICS. LABA means long-acting beta agonists like formoterol. LAMA means long-acting muscarinic antagonists like ipratropium, tiotropium. We use tiotropium more commonly than ipratropium. There are others also. And ICS means steroids. So all three being taken, and yet the patient keeps on getting exacerbation. Remember that you have this option. Of course, you will be referring, but remember that there is an option for such patients. Modafinil or armodafinil are more useful in which one of these situations? You know what are modafinil and armodafinil? What are they? They are basically awakening agents. They keep the patient awake. And patients of OSA have daytime drowsiness. So to prevent daytime drowsiness, in a patient who is already taking a CPAP machine at night, here is the role of modafinil, brand name Mod Alert, for example, or armodafinil, brand name Wake Alert, for example, WAK, Wake Alert, for example. These patients will be probably benefited in their daytime somnolence. Which one of the following is now a pulmonary indication of gabapentin? Symptomatic treatment of non-resolving dry hacking cough. Now, this is one thing that you can use. You don't need a specialist referral for this. We know that many viral infections are followed by a prolonged cough, 2 weeks, 3 weeks, 4 weeks, and does not resolve. We give them codeine syrup, we give them antihistamines, and steroid inhalations, nebulizers, and still their cough is hacking. These patients, it is thought that they have a neuralgic origin of cough, meaning nerves in the bronchial tree are stimulated, and therefore gabapentin as an anti-neuralgic agent has been found useful in these patients. You can start with 100 milligram OD or BD and go up to 400, 600 milligrams, and can give it as a symptomatic treatment. This is no cure. As a symptomatic treatment till the cough decides to resolve itself. 5. Why are inhaled corticosteroids not first-line agents in COPD? Why are they not? Because of greater risk of greater risk of pneumonia and lesser efficacy in asthma. I hope you are taking the right answers in your book as you go along. This is surprising, right? Inhaled corticosteroids can can precipitate or predispose to pneumonia in a patient with COPD. Not as much in asthma as in COPD. So, which is why ICS are not the first line drugs. They are used only if LABA, LAMA have not been adequately effective. In URTI, if an antibiotic is started and then one realizes the infection is viral, one must not complete the course. There are so many patients of influenza or COVID who come to you with very bad cough. You think, okay, yellow sputum hai, अपन azithromycin या कुछ दे देते हैं. You must stop as soon as you realize maybe the swab will come positive or maybe आपकी बत्ती चलेगी कि ये viral था. तो तभी you have to stop abruptly. The misconcept in the lay people also कि एक बार शुरू किया तो खत्म करने का is incorrect. You do not continue the medicine. 4 puffs per day of Seroflow 250 or Foracort 200 can cause systemic absorption. True. So any patient who's on 4 puffs per day, this is metered dose. This is not Rotacaps. This is metered, not dry powder inhalations. This is metered dose. Dry powder have a double the dose requirement for causing systemic absorption. So metered dose inhalation 4 puff लिया इसका ये strength का So you have to just tell them, okay, you can't take it for a very long period. Then you will start seeing Cushingoid facies or BP uncontrolled, diabetes uncontrolled, adrenal suppression, etc. The duration is not defined कि कितना दिन देंगे ये dose में तो होगा, but you must realize कि you have to be aware of these side effects in a patient on high dose. Next, in COPD exacerbation, which one of the following must be given? It's a thumb rule. Steroids must be given in all COPD exacerbations for 5 days. And the dose is irrespective of body weight. 40 milligram per day for 5 days. You can give it 20 BD, 40 OD, whatever way you like. 9. Vonoprazan is a new molecule in GI pharmacology. What is it approved for? It is approved for GERD and H. pylori. We know that PPIs are very commonly used. We know that PPIs have a problem with long-term side effects on the kidney, on the GI tract, precipitation of increased incidence of fracture, etc. All that probably you already know. This substitute drug, vonoprazan, is touted to be safer. We don't know really, because post-marketing side effects will be apparent soon. Even in PPI, we got to know about more major side effects after the PPI were used for a long term. But similarly, vonoprazan has one advantage. It is more efficacious in patients with reflux and more efficacious in patients with H. pylori. So in H. pylori, they have found that just one antibiotic, that is amoxicillin with vonoprazan. Normally we have a triple or a 4 drug combination. But here just 2 drugs, vonoprazan and amoxicillin, may give a cure rate of as high as 75%. Whereas triple drug, clarithromycin, vonoprazan and amoxicillin, clarithromycin, amoxicillin, can give 95% plus cure rate in H. pylori. So maybe vonoprazan is a little better than PPI there. The mode of action is something related to potassium channels. I'm not sure. Do you remember that? Something related to potassium channels instead of sodium channels for PPI, but I'm not 100% sure. I will check. Next would be ecotiamide. Is useful in postprandial fullness due to non-ulcer dyspepsia. Many patients will tell you that they become very full after eating. Any patient who tells you this and has a recent onset of this problem, you must investigate for stomach cancer, first of all. Don't give ecotiamide as a symptomatic drug. Postprandial fullness of recent onset must be investigated for CA stomach. And of course, there are other causes like diabetic gastroparesis, etc. But if the patient has chronic postprandial fullness and you want to give symptomatic treatment, normally we used to give either a perinom like prokinetic drug, which we can't give long term. Now this drug is there, ecotiamide. This drug can be tried, expensive, I think 20 to 30 rupees per tablet, and 100 milligram TDS would be the dose, or 300 milligram OD as a sustained release. You can use AcoGut, for example, is a brand name. You can use this for postprandial symptomatic treatment. When to give is, I think it is before food. I have never used it, but I think it would be before food. Next would be prucalopride. Prucalopride is a prokinetic drug which works on the colon. We know that prokinetic drugs like mosapride work on the etopride, mosapride is what we use commonly, work on the upper GI tract for reflux or esophagus. But this particular drug works on the colon and it is used for chronic constipation, approved for chiefly chronic constipation. Prucalopride. Expensive, per bowel movement, 23 rupees at least. 1 milligram in the senior citizen, those above 75, give 1 milligram. In the younger people, you can start with 1 and go to 2 milligram. No, this can be given. The 1 week, 2 week thing was with PEG, polyethylene glycol, but now we know that PEG also can be given for long term. PEG has to be given with electrolytes if you are giving long term, just telling you. Okay. Next, sodium alginate, a component of some antacid liquids, is a medicine that forms a raft above the acid. You know the brand names? Everything has raft in them as a suffix. So this raft, what is a raft? Sodium alginate coats the upper layer of the acid. This raft, which forms in the stomach, will not allow the acid to come up into the esophagus. Hence, the principal use of this molecule is reflux related esophagus discomfort, pyrosis or retrosternal burning. The sodium alginate that is available is mostly with other antacids, other liquid antacids like magnesium and aluminum compounds. Why do we use a mix of all these things? Because whatever acid is there has to be neutralized by our standard antacids, and then alginate will help in the third way. Sodium alginate, I use Alpan raft, for example. Somebody also mentioned one. Many of them. So yeah, Gaviscon also maybe. I'm not sure, but yeah, many brand names are there. Next, mebevorin is principally indicated in colic. Mebevorin is an antispasmodic, an expensive antispasmodic for IBS. We don't use it in as antispasmodic for acute intestinal colics. We use it mainly for IBS. And Mebespa, Colospa are brand names. So 135 milligram TDS or 200 BD. Question number 14. Rifaximin is used in this dose for SIBO. SIBO, small intestinal bacterial overgrowth, is an underdiagnosed condition. It's a general practitioner's condition. It is not a rare disease. SIBO basically will present with one predominant symptom called bloating. Bloating with or without diarrhea of recent onset is, you should suspect SIBO. Can you diagnose SIBO? Yeah, there are tests for diagnosing. There's a breath test for hydrogen, for example. But often SIBO is clinically thought of in a patient who acutely presents with bloat or bloating. And if there is diarrhea, then it kind of increases the sensitivity of diagnosis. Such patients, you have to give rifaximin as the drug of choice. We can give doxycycline also. We can give other antibiotics which work against gram-negative organisms. But rifaximin is costly but effective. 550 TDS, 7 days is the SIBO dose. The traveler's diarrhea dose is 200 TDS for 3 days. So traveler's diarrhea is a lower dose and SIBO is a higher dose. That ends our 14 first round questions. Shall we go to the second part of the quiz? Please continue. Close the book, close the book, close the book.